These respiratory issues include asthma, bronchitis, and emphysema. These are reactive airway disease, basically. Um, Mostly when we say reactive airway disease, we're talking about asthma. Sometimes all this can be considered a COPD, chronic obstructive lung disease. Um, it can be emphysema, bronchitis. Asthma is a little bit separate, but these two, you can call them chronic obstructive lung disease. Asthma is mostly inflammatory disease caused by some allergies. So we just pushed that one into the reactive airway disease, and you have a bronchospasm, constriction from the muscle from the reaction. And so you have the, like obstructive kind of airway problem. And bronchitis is just a recurrent, they have a recurrent infection. So these people have a recurrent infection, make a lot of sputum, and they have ongoing lung infections back and forth. Emphysema is really the lung get damaged that it loses elasticity. Therefore, you have trapping of air in the lungs. So their lungs are usually big because the air doesn't come out and it trapped, and they have what we call small tiny sacs, which are bullae or bleb, and this can rupture and then develop pneumothorax. But the detail doesn't matter. When they give you any respiratory question, they can either state it as an asthma or bronchitis or emphysema. So then you can think about what to do with them. If it's asthma, you know specifically how they're going to present. They will be wheezing. Bronchitis, usually they'll come in with a cough, infection, similar to like emphysema. Smoking is one of the common cause of emphysema in people. So that's the three types. Um, they the problem is it's very difficult to treat. So there's a lot of medication. So all these people will take multiple medication to treat their problem. So we'll talk about some of them quickly. Most of the I'll be using asthma as an example. So this is the actual airway, okay, and then we have our lung here like that surrounding this airway. Okay, so within the airway, we have muscles, okay, smooth muscles surrounding it. These can constrict it or dilate it. Okay, in asthma, due to some allergen coming, causes reaction, your body reacting to it. So there's a constriction of the airway by the muscle. So the muscle contract. And so you constrict the airway, the inflammation. So there's one inflammation, okay? Inflammation. Then there's two constriction. So two, there's bronchoconstriction. You have bronchoconstriction from the smooth muscle itself. And so you have two things going on that your body needs to take care of. So you have the bronchoconstriction. Based on that, your management is going to follow that pattern. So you have inflammation, bronchospasm, and constriction. And so air cannot go into the tube. And the common symptoms is they wheeze. So they have wheezing kind of presentation. Any asthma patient that is not wheezing, it's a problem. We call it silent chest. You don't want that. Don't want a silent chest. If you treat an asthma patient with Albuterol, they should still wheeze. But if they don't wheezing, that means they're tired and they're about to go into bronchospasm. So the Albuterol, which is a beta 2 agonist, okay, it's a beta 2 agonist. What does that mean? So your lung has you have two lungs, okay, and each of them has beta 2 receptors. Your heart has beta 1 receptor. So these beta agonists they help with the smooth muscle relaxation. So the albuterol come and bind to that, relaxes the smooth muscle and open the airway from the constriction, and then air can go in. So that is the way they do their thing. So albuterol is the most common one we use, and is short acting. You give it to the patient within 5 to 15 minutes, he has done its effect quickly. It's very quick and short acting. So because of that, we use it for acute phase asthma. So acute phase, when somebody coming with the exacerbation, we give them an albuterol. Okay, and then it helped with the bronchoconstriction. So and it dilated. So it dilated. So it's used for acute phase. The second one is salmeterol. This one is a long acting. It's also a beta agonist, but it's for long acting. So this is not for acute. And you expect them to confuse you with that. This is not for acute asthma exacerbation. Somebody come with asthma, albuterol, no salmeterol. They don't get it. Okay. And then the last one is terbutaline. It's a little bit different. It has different, is a also bronchodilator, but it has different name. It doesn't follow the raw thing. It has a role in OB also. So pay attention so that you don't get confused with that. The same medication they can use in OB is the same thing that you can also use it over here in asthma. So be careful with that medication. The most important thing I want to talk about is, I think I should talk about is albuterol, the way it functions, because that's what they will ask you. So it's a beta agonist. What does that mean? It's like epinephrine. You give somebody epinephrine, what happens? They bind to beta 1 receptors in your heart, and then they speed up your heart. Your blood pressure goes up, everything goes up. The same thing, beta agonist 2 is do the same thing. So if you give somebody albuterol, it will in the lung, well, it dilates the the bronchial and allow air to pass through. So it's better. The asthma patient feel much better, but the rest of the body doesn't like it. So they have palpitation. Okay, this is what they will ask you, side effect. So give somebody albuterol, palpitation. We get tachycardia. So if I give you albuterol and I see heart rate of 110, I shouldn't worry. It's expected. I'm not being sharp about it. So I shouldn't worry about it at all. If you give some albuterol and he's very nervous, he's just panting around, pacing, can't do anything, yes, that's normal. If the hand starts shaking, they have tremor, well, that's normal because I give you something that will speed you up. And then if you give them albuterol and they don't want to sleep, insomnia, okay, that is okay. And this is what some people forget. If this is your cell, potassium can be pushed inside the cell. Albuterol causes potassium to be pushed inside the cell. So it causes hypokalemia. So we can use it to treat hyperkalemia. If somebody glucose, potassium is high, you can give them albuterol also in addition with insulin glucose. So it also causes hypokalemia. This pay attention. And then if the patient is diabetic, unfortunately, it make the insulin, a little bit of insulin resistance, basically. So that is the easy way to explain it to you. So if you take metformin once a day or twice a day, you may have to 500 twice a day. You may have to increase the dose because you need more insulin to get rid of your sugar. So they will have there was the way to say it. I can put it like increased glucose. So their glucose go up. So they will have high glucose. So hyperglycemia, basically, hyperglycemia. So you see what I've done? Side effect, SATA question right there. You get one SATA question. There you go. That's all. That's the way the examiner will do that. That's exactly what I've done for you. SATA question. As you study, think like that. That's the SATA side effect. So that's your side effect in SATA question right there. So that's that. That's if they want to ask you mostly albuterol side effect because it's acute exacerbation. Usually, most of the cases you see is patient who come in acute. So you won't worry about Salmeterol or Terbutaline. But if they ask you questions about somebody coming with the exacerbation, don't choose this. This is for long term. This is combined with steroids, and you can use for long term. This is also combined with steroids. So there's inhaler that it can be used for them. So the same line, we want to keep on dilating the bronchi, okay? Apart from the beta 2 agonists, where these anticholinergics, they are inhalers, and you know them, Ipratropium, and the same thing like that, Theophylline, they are anticholinergics. So they also act on the smooth muscles and they dilate it. Whenever you hear anticholinergic in your when you're studying something, a bunch of buzzwords should be coming in your head. Okay, this is what I should be teaching the patient. This is what I should be doing. That's how you connect things in science. It makes sense that the pharmacology will not be just pharmacology. You start thinking it's an anticholinergic. I know what kind of side effect that you expect, and you don't have to memorize it. So that's the way it goes. They are all inhalers. This is notorious. Tiotropium. It comes in a capsule. So guess what? You got to teach the patient um, fundamentals. You see, it's a capsule. If you come in the capsule, no chew, no crash. They would think it come like that. It's in a capsule. Unfortunately, they would think they can swallow it. No, you can't swallow it either, because it's an inhaler. No swallowing, no crashing, no chewing. You open the spacer and you put it in the spacer and you inhale it. So the spacer will pierce the medication and it come in an inhaled form. But unfortunately, it comes as a capsule. So just know this, if they trick you with that tropin, even though it's inhaled, it comes in the capsule form that you put inside the spacer to inhale it. Okay, so they are bronchodilators, but they have side effect of anticholinergic. And when you hear anticholinergic, certain buzzwords should be coming out of your mouth. There's three places you always say anticholinergic: your eyes, your mouth, your bowel, and your bladder. Every time you hear anticholinergic, you said your eyes, your mouth, your bowel, and bladder. It's just from you coming from the top down. So your eyes, then your mouth, your bowel, and your bladder. That's the way I remember it. You come from the head down. So your eyes, well, you should avoid it in glaucoma, okay? Angle glaucoma, narrow angle glaucoma. It's not good for them. Your mouth, well, your mouth is going to dry up, okay? So you know what kind of teaching you're going to teach them. Okay, they have sugar-free, drink a lot of water, something to prevent your mouth from drying up, chewing gum, all the teaching. That's your SATA there. Chewing gum, SATA question that they can ask you about this medication or the side effect. Bowel, well, they get constipated, okay, because the cholinergic effect. And the bladder, well, urinary retention. You see what I'm doing? So if somebody has a BPH, well, no, 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 no. You got to cancel them and tell them you're going to be in trouble. Okay, so they are aware about it. If somebody already had obstruction or ileus, well, you're telling them these are the side effects we're going to get. So as you study, think about that. Think as you think about it. And it become when you see the question, you're not surprised. So one medication, we're not even talking about what it does. We're talking about its side effect. You can see how the side effects go across systems, and that is what medicine does. The next one is notoriously dangerous, okay? They are Methylxanthines, like the same thing with treating inflammation and bronchodilation. These two guys can also do both. And the way to remember them in fillings. So the common one they ask you is Theophylline, and you have to know everything about Theophylline because it's a medication with a lot of side effects. Okay, so we'll be talking about Theophylline. It's one of those medications you have to know a code. He's a bronchodilator and then help with inflammation, narrow therapeutic range 10 to 20. So this is therapeutic range. It's very narrow. So you have to do what? Frequent lab check. So you tell your patient they will need to be, so this I'll put education here right there while we do it. So you need lab work frequently. You check the lab 30 minutes after administration to make sure there's no side effect on it. Okay, there is a bunch of reaction. You have a lot of reaction with other medications. It affects the liver. Okay, this is key. Theophylline has bad effect on the liver. Because of that, look at the teaching we're going to do. First, we check the lab. So make sure you come and check the lab. There's one thing I've done. I mean, I came up with this strategy. It's in my head. I know it, but if you know it, you can remember. I call it the 3 C's and the 2 A's. So the 3 C's, the specific medication that you avoid, Salmeterol. Okay, Salmeterol. This is they cannot take this medication at all. Another C is caffeine. Don't take caffeine. So no coffee. Don't go to Starbucks. And the third C is ciprofloxacin. So if we have UTI infection, it's getting infection, the doctor should know you can't get ciprofloxacin. So fluorochronin example. So ciprofloxacin, they can get it. No caffeine, no Salmeterol, and no ciprofloxacin. And the 2 A's is related to the liver. Okay. So you can say C liver, cirrhosis of the liver is Theophylline. So Salmeterol, caffeine, and ciprofloxacin. And the 2 A's is what common thing that affects the liver, where no alcohol, don't drink alcohol. What other common thing affect the liver that you can get in Walmart? Acetaminophen. Okay. So acetaminophen. So you see how you can remember the side effects. 3 C's and 2 A's. And the A's are for the liver because it has liver toxicity. No alcohol, no tar, no acetaminophen. And the 3 C's, Salmeterol, caffeine, and then ciprofloxacin. So that's all you don't need to. The side effect, though, the big side effect for this medication is seizure. And then liver toxicity. So those are the, and the third one is cardiac arrhythmia. So that's why you got to be careful. So they have you can cause seizure in them, you can liver toxicity, and then cardiac arrhythmia. These are the things that they like to test about. The education you give the patient, the 3 C's and the 2 A's, and the need for lab work. You have to make sure you check lab for the liver function, and then therapeutic range, and the side effect is a seizure, cardiac, and liver injury. Now we got to take care of the inflammation. So I told you there's inflammation and bronchoconstriction. The steroid are for the inflammation. There's the oral form, there's the inhaled form, and there's the IV form. Acute phase, they get inhaled form. If they are in asthma, staticus, that means they are not being, you can't get them out of the acute phase. No matter what you've given them, they're going down. Asthmatic staticus, you need to give them IV steroid to um, to get them out of it. So status asthmaticus is bad. They cannot get it. So that's when this is the people they get status asthmaticus. They can't get out of it. So you got to give them IV steroid. Most of the time is oral steroid, and this is combined. Some of the inhaled steroid is combined with albuterol, and you can take it through the inhaler without any problem. And whenever you hear steroids, by this time you're going to take your test. Something should be ringing your head. So as examiner, they can trick you. Okay, they can give you asthma patient is on steroid for 6 months. What do you think? Asthma patient, steroid. So steroid, 6 months. Is being on steroid, oral steroid for 6 months to control the asthma. Well, you've put this patient, he become a cushion guy. It's now cushion. He's being cushionoid. That's what we call it. He's a cushion-like guy now. And you know what to expect in a cushion, right? Insomnia, he's not going to sleep. He's going to gain weight, a lot of steroids, right? I mean, you know everything. His sugar goes up, hyperglycemia. Well, guess what? Fluid overloaded, okay? And hypertension, all these things, it should be just coming in, just like that. You don't even have to, naturally, it will come. I mean, those are the same things you know about Cushing. So you're bringing that from endocrine to this in a respiratory cell. If you're on steroid for a long time, as you see weight gain, high glucose, fluid overloaded, Cushionoid, moon phase, buffalo hump, all the signs of, I mean, if they put it in a SATA question, it's possible it can take a long time to get those symptoms, but you expect that because they expect you to know that this is part of the pathophysiology of the disease. If you're on steroid, yeah. And then your teaching follow the same pathophysiology that you're teaching. You tell them if you be on steroid for 6 months, well, we cannot stop it right away. We will taper it. Otherwise, what do you think happened? Well, they go into crisis, adrenal crisis. So we don't want adrenal crisis because your adrenal gland shut down and they will be in shock. Hypertension, natremia, hyperkalemia, all the things you expect in adrenal crisis. We don't want that. Okay. The inhale form, you got to teach them that when they inhale, they wash your mouth. Because if you don't teach them, they get what? Oral candidiasis. So this is common. If you see it in who do you see? Somebody on asthma, inhale corticosteroid, they will tell you white patches in their mouth, oral mucosa. All they're telling you is oral candidiasis. They want you to deduce from that. So you tell them to wash their mouth, don't taper it. And then they should not take what? NSAID. Okay, this is very important. Anybody on steroid should be on PPI to prevent peptic ulcer disease. This is critical, and this is a passing level question. If they give it to you, you're passing because they want you to think it's an steroid, avoid NSAID because you get peptic ulcer disease. So if the patient had what? Tarry, black stool, okay, tarry, black stool, you tell them, no, that's not normal, okay? We got to stop something, or we give you something to protect your stomach from getting ulcer because of the steroid. You see what I'm doing? And if they are over 65 years old, female, you said, please take some calcium, okay? Calcium and vitamin D. Why? osteoporosis. You see what I'm doing? I'm just putting it together. It just came into my head and then just putting it together because that's what it happened. I mean, you have to connect it together. Steroid causes osteoporosis. Therefore, you don't need calcium. You need, if you're older, to prevent osteoporosis, calcium and vitamin D to help with that. You're just preventing it. Okay. And so that's some of the things you need to tell them to prevent that problem. Okay, so that's all on that portion of it. In acute phase, they get a inhaled steroid. If it doesn't work, they get some IV. And the last one is these leukotrienes. I don't want to bother you, but they have this LB12. Basically, the leukotriene is part of the histamine pathway. Don't worry about the mechanism too much. But basically, what it does is inflammation and bronchodilation. They're very good, but they're also very powerful and they have a lot of side effects. So you got to be careful with them. They're very good medication. These are for long term, long term. Some people, it help. That's what they need. So they are on it for a long term, and it help with exercise. Exercise induce asthma. It decreases. So they use it before they exercise, and or they use it for a long time to prevent exercise-induced asthma because we think exercise-induced is released by histamine and other histamine derivative like leukotrienes, which causes bronchoconstriction. So therefore, these are very good for that. Unfortunately, they have side effects, and you see their names whenever a medication has some fancy names. Yeah, it's not a good one. It's not a good one. The Montelukast, you can use it for kids more than 1 year old. The Zoloton, you have to wait for 12 years. And the last one is Zaflocast, 5 years. Okay. These two, Zoloton, disease, okay, affect the liver. So it's a liver problem. So you know things that affect the liver always causes multiple interactions. So if they ask you questions, somebody taking Zolotin and Zifaloxacast cannot drink alcohol. So you educate them about it, and that will help with that. So that's the risk factors you tell them, and that I don't think they ask questions too much about this because they are for chronic. It's usually Albuterol and Theophylline. If you know everything about it, and you know that the other ones are for long term, you go in with pharmacology, and you know the side effect of the Albuterol. You're good for pharmacology in terms of respiratory related to COPD. So let's try some knowledge. So SATA, whenever I do SATA question, it's the summary of the lecture and I'll put it and see if you can take it. That's what I think you do. Which of the following assessments the nurse should expect to find? Okay. The client with known asthma receive Albuterol. So then you rewrite it again. Expectation Albuterol. So if I give you a beta 2 agonist, what will happen? Well, everything goes up. Bradycardia, no, heart rate goes up. Palpitation, good. Sleeping 3 hours a night, good. Insomnia. Potassium 3.4, yeah. Hypokalemia. Tremor, good. Daytime sleepiness, yes. If you don't sleep at night, you sleep during the day. And this is the same thing as obstructive sleep apnea people. Just a knowledge check over there, just trying to fill in the gap for you. Obstructive sleep apnea people, because they can't sleep at night, daytime, they sleep. So that's why we have a this thing that we can see what exactly their problem is. So then white oral mucosal patches. Yeah, that's not Albuterol, right? It is inhaled steroid, non-inhaled bronchodilator. So this is wrong. So the same thing, SATA question. A client present with acute asthma exacerbation. Which prescription should the nurse expect? So acute asthma exacerbation. So that means patient is wheezing. One, I got to take care of inflammation. I got to take care of the bronchospasm and give them some oxygen. That's all. So inflammation, bronchospasm, and oxygen. Salmeterol, yeah, so it will help with the It's a bronchodilator. It help with the bronchoconstriction, but it's long term. It's no use for acute one. Albuterol, yes. Theophylline, no, long term. Inhaled steroid, yes. Inhaled bronchodilator, yes. Salutin is a long term, and propranolol, no way. It's not. It's a beta blocker, which is non-selective. It's a non-selective beta blocker. So it blocks beta 1 and beta 2. Non-selective are not good in asthma. What you want to be used in asthma is selective, and which are what we call BAM. These are bisoprostol, atenolol, and metoprolol. Propranolol is not good, so we can use it. So this is a summary. I hope you get something out of it. Keep charging. Take care of yourself. And then like this video on my YouTube and check it over there for more videos. Take care of yourself. Thank you very much for listening.